Okay, so let's unpack this. We have a massive stack of sources today, all focused on one central, really critical issue: the escalating global crisis of healthcare costs, efficiency, and access.
Right. It's a system under just staggering pressure pretty much everywhere.
And you, the listener, you want the shortcut, right? You want to be well-informed on its deepest problems, but also its most, well, radical potential solutions.
Indeed. For you, the mission isn't just seeing the symptoms like long wait times or high bills. It's about quickly understanding the core drivers of inefficiency and waste in these massive, um, complex systems.
And then grasping the innovative strategies being deployed to fix it, some of which are, frankly, pretty controversial.
Exactly. It's about getting to the why and the what next.
Our sources today are pulling no punches. They range from deep academic studies, really drilling down into where billions in avoidable costs hide in systems like the U.S.,
Billions, yeah, with a B.
to, candid observations on the fundamental struggles of universal healthcare models, like the UK's NHS, and even some unsettling historical critiques of modern medicine's corporate origins.
And what's really fascinating here, I think, is that we aren't just looking at clinical or, purely medical problems. We're actually dealing with profound management issues, economic failures, political failures,
Systemic.
totally systemic. We have to first understand healthcare as a complex adaptive system, a CAS. Now, that isn't just jargon, okay?
Right. What does that mean practically?
It means every effort to improve efficiency is nonlinear. You pull one lever over here, maybe try to cut costs.
And something unexpected pops up over there.
Precisely. You often get like three unintended consequences somewhere else in the system. It adapts, but not always in the way you plan.
That structural reality, that CAS nature, it explains why real reform is just so incredibly difficult.
Absolutely.
So our deep dive today, it's going to be structured around three critical pillars. First, we'll dissect the astronomical cost of inefficiency. We need to identify the staggering dollar amounts tied up in waste.
Get a handle on the scale of the problem.
Exactly. Then second, we'll thoroughly analyze the practical strategies for improvement. We're talking technology, payment reform, operational shifts, what's actually being tried.
And what shows promise.
And finally, we have to connect all this back to the enduring issues of, well, power, wealth, and systemic inequality, because those factors often determine who gets care and how efficiently it's delivered.
You can't separate the economics and the politics from the medicine here. It's all interwoven.
Okay, here's where it gets really interesting. When we talk about waste, we're talking about numbers that almost defy comprehension. One study in our sources suggests that total potential healthcare savings just in the U.S. alone could exceed $1.06 trillion annually.
Yeah, that number over $1 trillion is just colossal. It's hard to even wrap your head around it.
To put that in perspective for you, that represents over 34% of yearly national healthcare expenditures, money that could theoretically be avoided or, repurposed for better care.
And when researchers drill down into that, approximately $666.7 billion of that trillion plus is considered immediate avoidable spending, things we could potentially fix right now.
Okay, $666.7 billion. That's still huge.
It is. And it's broken down into 10 major categories that really reveal the system's structural flaws. Hashtag 1.1, mapping the biggest categories of avoidable costs. The $666.7 billion problem.
So let's break down the biggest chunks of this. $666.7 billion problem. What's the single biggest drain on the system, according to this?
Well, that would be inappropriate or non-beneficial treatment. That hits the system for $192 billion.
$192 billion.
Wow.
Yeah, that's 28.8% of all the avoidable costs we just mentioned. The core issue here is basically overtreatment.
Care that patients may not actually benefit from.
Exactly. Sometimes it's driven by, defensive medicine doctors worried about lawsuits, but mostly it's fueled by the old fee-for-service model. The system that basically incentivizes volume over value.
Precisely. If you get paid for every single procedure, every test you run, well, you tend to do more of them, whether they're truly necessary or not, okay?
Okay, so that's the clinical waste, doing too much stuff. What about the structural inefficiency? That seemed to be right behind it in the numbers.
Correct. Unnecessary administrative expenses and excess costs. They come in at a staggering $180 billion.
Another huge number. 180 billion.
Represents 27% of avoidable costs. And this is purely the cost of bureaucracy. It's the sheer complexity inherent in systems like the U.S.
You mean like dealing with all the different insurance companies?
Exactly that. Providers might have to interact with hundreds of different payers, insurance companies, government programs, each with their own different billing codes, different approval processes, different utilization reviews.
It sounds like a nightmare.
It's an administrative labyrinth. And it requires massive staffing, specialized software just to manage the paperwork, and all that administrative churn. It adds zero actual value to a patient's health.
Just cost.
Pure overhead cost, yeah.
We also, unfortunately, have to acknowledge that outright fraud seems to be, well, baked into these figures, too.
We do. The sources point to Medicaid fraud, waste, and abuse accounting for a huge $120 billion.
$120 billion lost to fraud and misuse.
That's the estimate, yeah. Or 18.0% of that total avoidable spending figure we're dissecting. This money is just lost to theft, to misuse, and it requires constant monitoring, enforcement resources, just trying to contain it.
But, one area seems like such a glaring kind of low-hanging fruit for immediate savings. It's something the system, for whatever reason, seems resistant to fully tackling the medications we prescribe.
Absolutely. The continued use of name brand medications over chemically identical generics. That accounts for $70.8 billion in avoidable costs.
$70 billion, just by using the generic instead of the brand name.
That's the potential saving, yes. If generics offer the same quality, the same efficacy, the same safety profiles, which the FDA confirms they do, then why is this $70 billion avoidable spending still happening year after year?
Yeah, why? Is the system just, I don't know, financially rigged through aggressive lobbying by pharma companies? Or is this more about physician preference or maybe patients wanting the familiar brand?
It's likely a combination, but the sources suggest it's fundamentally economic. They point to really intensive pharmaceutical marketing directed at doctors, legislative hurdles that protect brand patents, maybe longer than necessary.
Keeping cheaper alternatives off the market.
Right. And physicians, they're trained and constantly marketed to by brand representatives. Plus, patients, too, they often carry this maybe misplaced perception that the name brand must somehow be superior.
Even if the active ingredient is identical.
Exactly. So this cultural inertia, combined with the financial incentives, maintains the high cost of drugs. It directly benefits the patent holders, but it comes at the expense of systemic efficiency and overall affordability.
Okay. And finally, in this breakdown, we can't overlook the impact of just fragmented care. The patient who kind of falls through the bureaucratic slots between different doctors or hospitals.
Yeah, that's the $35 billion care coordination failure. It's a huge problem. Picture the ping pong patient, maybe someone elderly, or someone with multiple chronic conditions.
Bouncing between specialists.
Right. Or they get discharged from the hospital, but there's no proper follow-up schedule with their primary care doctor. Maybe they miss picking up a new prescription or don't understand how to take it. Then they develop complications.
And end up back in the hospital.
Exactly. This fragmented care leads directly to hospital readmissions, declines in their functional status, increased dependency, especially for the chronically ill who need really seamless transitions between different providers.
And the cost of just one of those avoidable readmissions must be huge.
Oh, absolutely. It can easily eclipse the cost of months, maybe even years of effective coordinated primary care that could have prevented it in the first place.
These huge numbers, the billions we're talking about, they aren't just abstract deficits on a spreadsheet. They're reflected right on the ground in really tragic ways, particularly those high-traffic, high-risk environments like hospitals and emergency departments.
Yes, absolutely. Let's look at hospital-associated infections, HAIs. These are often preventable errors, yet they cost the system $33 billion. That's 5% of the avoidable costs we've been discussing.
Preventable infections costing $33 billion.
That's the estimate. And experts believe at least 50% of these HAIs are preventable. They often occur in high acuity settings like the ICU, maybe via invasive devices like central lines or ventilators. It often comes down to failures in basic infection control protocols, hand hygiene, sterile techniques.
Just fundamental clinical practice.
Right, simple things sometimes, but with huge consequences.
And the sources also detail how this failure, this risk of infection, can compound and spread into the wider environment too, right? Through waste.
Precisely. This links directly to the risks associated with medical waste management. When hazardous waste, things like used sharps, infectious bodily fluids, contaminated materials is improperly handled, it risks spreading microorganisms outside the immediate patient care area or even outside the facility.
Who's most at risk there?
Well, we see nurses and clinical staff particularly at risk from things like accidental needle prick injuries. But also, if waste isn't disposed of correctly through uncontrolled dumping or maybe poor incineration, the surrounding population could potentially be at risk too.
So proper waste handling is critical.
Absolutely vital. Effective, sometimes simple strategies like clear 3-container sorting systems for different types of waste are really crucial for mitigating these environmental and occupational health risks. It's another aspect of system efficiency.
Okay, let's switch focus slightly to the front door of many health systems. The emergency department, the ED. It's often targeted for cost savings, isn't it? Based on this narrative that it's frequently misused by people seeking non-urgent care.
Yeah, that narrative is really popular, but it needs some serious scrutiny. Actual data, like one study from 2016 cited in our sources, showed that only about 4.3% of ED visits were truly classified as non-urgent.
Only 4.3%. That's much lower than you often hear.
It is. However, the ED is undeniably an expensive safety net, and it suffers from chronic overcrowding in many places. This is often made worse by nationwide shortages of nurses and other crucial staff.
And that overcrowding has knock-on effects.
Big time. It leads to longer waits for everyone, lower patient satisfaction, definitely. But critically, it also increases the risk of medical errors simply because stressed staff are working under severe pressure, often for long hours.
Let's talk about the economic reality of that overcrowding for a minute. How does the cost of treating, say, the next patient change when the system is already strained like that?
This is where some basic economic analysis really helps clarify things. We look at marginal costs, the MC, versus average costs, the AC. Think of it like this. The average cost of treating a patient includes all the fixed costs, the rent for the building, the expensive MRI machine, the baseline staffing. But the marginal cost, that's the cost of treating one additional patient when the ED is already, say, at 150% capacity.
That cost must shoot up.
It explodes exponentially because now staff are working overtime. Maybe agency nurses are being called in at higher rates, resources are being diverted inefficiently, treatment delays might occur, which lead to patients getting sicker, requiring more complex, more expensive interventions later on.
So managing that flow is key to managing costs.
Absolutely. Reducing patient volume when the system is strained significantly lowers the overall cost burden because you're keeping those marginal costs from spiraling out of control. You're operating closer to optimal efficiency.
So the goal then becomes shifting genuinely non-urgent care out of that high-cost, high-stress ED environment.
Yeah.
And our sources suggest something interesting here, that patient anxiety is actually a massive driver of those unnecessary visits.
That is a really critical insight, yes. A significant percentage of unnecessary ED visits, not just in the US but worldwide, seem to be driven by patient anxiety and maybe a lack of tools or confidence to differentiate relatively minor symptoms from a genuinely serious illness.
People are scared, they don't know what's wrong, so they head to the ED just in case.
Understandably so in many cases. But this is where innovation aimed squarely at patient empowerment becomes absolutely crucial. We have sources discussing a tool called Dr. Maya GPT.
Dr. Maya GPT. Tell me about that.
Well, it was created by a Dr. Kadyali Srivatsa, and the method uses simplified Maya color-coded symptoms and signs. The idea is to help individuals differentiate minor issues from potentially serious illness or infection themselves.
So it's like a direct countermeasure to that fear-driven visit you mentioned, giving people information.
Exactly. The source material notes that Dr. Srivatsa designed this simplified methodology after spending years observing, collecting data, and compiling a list of really common presenting symptoms that consistently made people anxious.
The things that send people running to the doctor unnecessarily.
Right. Resulting in wasted consultations, increased demand on the system, longer waiting times for everyone, and just ballooning basic healthcare costs worldwide. So by reducing what the source calls real from imaginary fear, Dr. Maya GPT aims to cut down on those wasted consultations, reduce cross-infection risk from crowded waiting rooms,
and potentially revolutionize that initial decision-making process for patients before they even hit the expensive safety net.
That's the potential, yes. That kind of empowerment, giving people tools to make informed decisions, is a really vital link to improving overall system efficiency. But the good news here is that the data doesn't just present a doom and gloom problem. It actually tells us pretty clearly where we should be investing to try and invert these incredibly high costs.
Okay, so where should the focus be?
We need to deploy strategies that basically, as their utilization goes up, overall costs should come down. And the big ones are technology, reformed payment structures, and really intense patient engagement and coordination. These are the levers. Hashtag TAG 2.1, the power of digital transformation, HIT and telemedicine.
Let's start with the one category that, according to the numbers you mentioned earlier, represents the single highest potential for cost recovery.
Right. That would be health information technology, or HIT. The projections here are just massive. It's expected to spur a reduction in health spending somewhere in the range of $142 billion to $371 billion per year.
Wow, that's a huge range, but even the low end is significant.
It is. And to really emphasize its importance, other data in the sources suggests HIT accounts for something like 65% of all potential healthcare savings in the U.S. It's the biggest piece of the puzzle.
And that makes intuitive sense, right? Because earlier you cited the inability to share patient information as the root of huge duplicative costs like unnecessary tests.
Precisely. Electronic health records, EHRs, things like the EPIC system, which one source mentioned cost a major hospital $55 million to implement. These systems are absolutely critical for stopping that kind of waste.
That specific example you gave earlier.
Yeah, that clinicians order unnecessary lab tests 13.7% of the time simply because they lack access to prior test results for that patient. That's nearly 14% of tests. Just pure waste because of an information gap.
And HIT ideally solves that.
It directly solves this by providing, hopefully, a single, standardized, easily accessible patient record. No more guessing if a test was done last week at a different clinic.
I mean, the implementation of these massive EHR systems, that $55 million example, it's often really difficult and expensive in itself, isn't it? It's not quite a magic bullet.
Oh, far from it. That $55 million investment isn't just for the software license. It's for the hardware, the years of training for staff, the complex integration with existing systems, and fighting the inherent ongoing challenges of interoperability.
Getting different hospital systems or different software platforms to actually talk to each other seamlessly.
Exactly. That remains a huge hurdle. Furthermore, EHRs, while beneficial in many ways, often contribute significantly to physician burnout. Clinicians can end up spending huge amounts of their time clicking boxes, charting, dealing with constant alerts.
Instead of interacting directly with patients.
Right, so the promise of HIT is immense, absolutely. But the actual implementation requires really careful management to ensure those efficiency gains aren't completely offset by workflow disruption and provider fatigue. It's a balancing act.
Okay, so beyond these static records, these EHRs, we've also seen just massive growth recently in remote care capabilities, right?
Yes, telemedicine is a key component here. Efficient utilization is projected to increase dramatically. And critically, studies suggest it could eliminate maybe 15% of routine physician office visits and perhaps 15% of emergency room visits too.
That could add up quickly.
It could, potentially saving employers, for instance, up to $6 billion annually just by shifting appropriate care to telehealth platforms. And especially for managing chronic conditions, diabetes, heart failure, COPD, telemedicine allows for more continuous proactive monitoring from home.
Preventing the acute crisis that sends someone to the ED.
Exactly. Preventing that acute crisis, which is always exponentially more expensive to treat than steady preventative management.
And we're also seeing innovation, sometimes quite simple innovation, in low-cost medical devices that directly impact resource waste and patient safety. Though, as you hinted earlier, sometimes that innovation gets stifled.
Yeah, this is a perfect illustration of that complex adaptive system idea in action. What happens when a potential efficiency gain conflicts with established professional norms or anxieties? The VenaKaiCan device is a concrete example from our sources.
Tell me about that one.
Okay, so it's described as a spring-loaded device specifically for intravenous cannulation, basically, starting an IV line. It apparently boasts a 94% success rate on the first attempt, even in small babies where veins are tiny and hard to hit.
Okay, that sounds really useful. Fewer painful pokes for the baby.
Right. Reduces nerve damage risk, reduces bleeding, and also reduces contaminated waste. Fewer failed attempts means fewer used needles and supplies. So it saves resources and improves safety.
Seems like a win-win, so what's the catch?
Well, the sources note that manufacturers had previously halted development of similar alternative devices based on a proven technique published way back in 1992. And the reason cited was a fear of de-skilling doctors.
De-skilling doctors, because the device makes it easier.
Apparently. The idea or the fear was that if a device makes a traditionally difficult skill easier, then maybe doctors lose that manual dexterity or judgment over time. So the desire to maintain those traditional, perhaps difficult professional skills sometimes seems to override the adoption of proven innovations that could dramatically improve efficiency and patient outcomes. It's a fascinating tension. Hashtag tag 2.2 reforming payment and coordination.
Okay, so technology definitely helps fix the operational side, the information flow, maybe even some procedures. But we still need structural and financial shifts, right?
Yeah.
To fix the underlying incentives that promote waste in the first place. That old fee-for-service model encouraged volume. What financial shift is supposed to be replacing it?
Yeah, the fundamental shift that's underway, albeit slowly and unevenly, is toward value-based purchasing, or VBP.
Value-based purchasing, what does that mean in practice?
It means the payment model aims to reward providers, hospitals, doctors who deliver better patient outcomes at lower overall costs. The entire focus shifts, instead of just paying for each individual service.
Like an assembly line.
Right. Instead, the focus moves to managing the cost and quality for an entire episode of care, say a knee replacement, from pre-op to recovery, or even managing the health of a whole population of patients over time.
So it moves away from the structure that incentivized just increasing the sheer volume of services, whether they were truly needed or not.
Exactly. Under VBP, ideally, the provider is now penalized for inefficiency, for complications, for readmissions. They're rewarded for keeping patients healthy and costs down, not just for activity.
And are we seeing alternative models being deployed successfully based on this idea?
Yeah.
Especially maybe in those high-pressure environments like the emergency department, which we already identified as a real pressure cooker?
We are. Alternative payment models, or APMs, are essential for making this transition happen. For instance, one model mentioned is the Acute Unscheduled Care Model, the AUCM.
Okay, what does that do?
It aims to provide emergency physicians with expanded tools, things like better access to transition services for patients being discharged, or integrated telehealth follow-up specifically to help them safely discharge patients who might otherwise have ended up in an expensive observation stay or even a full hospital admission.
Trying to avoid unnecessary admissions right at the front door.
Correct. Furthermore, there are bundled payment models being tested. These essentially hold the emergency physicians accountable for the total costs incurred by a patient over a defined period after they leave the ED, maybe 7 days, maybe 30 days.
So the ED docs have skin in the game for what happens next.
Precisely. It makes them think much more carefully about the whole continuum of care, the discharge plan, the follow-up communication, not just stabilizing the patient during that single high-cost visit and then handing them off.
You know, the success stories we hear about better care coordination, they really seem to emphasize the value of having robust primary care act as the central kind of intelligent pillar of the whole system.
Oh, absolutely. That's a consistent theme. Look at the example from Michigan's patient-centered medical homes, or PCMHs.
What do they find there?
These focused coordination efforts, centered around primary care, saw a 19% lower rate of ED visits among their patients compared to traditional care models, and a 9.4% reduction in the actual ED costs per member per month.
So investing in coordinated primary care actually saves money downstream in the expensive parts of the system.
Exactly. Good care coordination fundamentally means ensuring the right care is delivered at the right time, in the right setting, which is often not the hospital or the ED. And increasingly, this also means addressing non-traditional medical services that heavily influence health outcomes.
Things like transportation, housing, food security.
Yes, what we often call the social determinants of health. Recognizing that ensuring a patient has reliable transportation to their follow-up appointment or access to healthy food or stable housing, these things can be just as important, if not more so, in preventing downstream high-cost medical crises as prescribing the right medication. It's a broader view of healthcare. Hashtag 2.3, empowering the patient.
This raises a really important question, I think. We've looked at clinical failures like overtreatment. We've looked at management failures like administrative waste and poor coordination. But how much of the system's massive cost burden rests on the inability of the patient, the consumer, to navigate this incredibly complex system effectively?
That is potentially the $73 billion question, based on some estimates in our sources. We're talking about health literacy here.
Health literacy. Can you define that quickly?
Sure. It's basically an individual's ability to seek out, understand, and then actually use health information to make appropriate health decisions for themselves. It's sort of the opposite of the inherent complexity we see baked into the healthcare system.
And the numbers tied to deficiencies in health literacy, they're staggering, right?
They really are. Low health literacy is estimated to affect something like 80 million adults just in the U.S. And importantly, studies show it's an independent factor, meaning regardless of income or education level associated with increased healthcare costs and utilization.
Especially more ER visits.
Particularly more ER visits, yes. And more hospitalizations, poorer ability to manage chronic conditions, more medication errors, it all adds up. The potential annual savings just from effectively addressing these basic health literacy needs is estimated at around $73 billion nationally.
73 billion. Just by making health information easier to understand and use, it makes you wonder, how does the current complexity maybe inadvertently serve the existing financial model?
Well, it's structural, isn't it? You could argue that low health literacy, while perhaps not intentionally fostered, is actually a massive profit generator for the system as it stands.
So,
Because complex patient behavior confusion about symptoms, inability to manage conditions effectively at home, delaying care until it's an emergency leads to predictable, high-cost interventions. Think about it. If patients knew exactly how to manage their asthma or their diabetes cheaply and effectively at home.
or how to tell a minor infection from a serious one.
Right. That would dramatically reduce demand for the expensive specialty services, the emergency visits, the hospital stays that drive a huge chunk of corporate healthcare revenue. So you could argue that the system's complexity inadvertently maintains the power dynamic, keeping knowledge concentrated, and thus supports the prevailing profit model.
And this is where we loop back again to that Dr. Maya GPT concept you mentioned earlier, right? Its focus seems to be directly on reducing that fear of illness by empowering people with understandable knowledge.
Precisely. Dr. Srivatsa's methodology, as described, aims to essentially democratize that crucial initial diagnostic knowledge using those simplified color-coded systems. The stated goal is empowering individuals to conquer that fear of illness, to make more informed decisions for themselves.
Reducing that culture of dependency on constantly running to the doctor for every little thing.
That seems to be the aim, yes. And the sources suggest that integrating this kind of simplified diagnostic method with modern AI tools, like ChatGPT, could potentially provide instant, clear guidance, helping people conquer the fear of illness and infection that, as the source puts it, often makes humanity surrender their free will when it comes to health decisions.
Which ultimately results in systemic disparities because not everyone has equal access or ability to navigate the complex system.
Exactly. Empowerment through knowledge is presented as a way to counteract that.
And of course, perhaps the most direct and fundamentally simple cost saver, though often underutilized, is just basic preventative care.
Absolutely. It seems obvious, but the impact is huge. One analysis suggested that just increasing the utilization of proven, recommended clinical preventative services, things like screenings, vaccinations, counseling up to a 90% level across the population.
Which is still not 100%.
No, just 90%. Even that could result in total savings of at least $3.7 billion annually, and, perhaps more importantly, avert the loss of over 2 million life years each year. Prioritizing prevention saves money and saves lives down the line by mitigating those severe, expensive health crises that overload the system later on. It's the ultimate efficiency.
You know, listening to all this, it's becoming crystal clear that the problems run much deeper than just, say, bad management or a lack of the right technology. We've seen potential solutions like HIT, like value-based purchasing, consistently meeting resistance. We saw that example of the Then I Can device being potentially resisted due to a fear of de-skilling.
Right. The system pushes back.
It does. So we really have to ask why. Why is the system seemingly so terminally inefficient in some ways? Why is change so hard?
And to answer that, we need to look at the broader structural, political, and even historical forces at play. Our sources actually trace some of this resistance right back to the very moment modern medicine, as we know it, was structured. They argue the system was often built on a foundation of profit and control, not necessarily on the primary goal of universal, efficient care for all.
Okay, this sounds provocative. The sources suggest that modern medicine, specifically the allopathic focus, synthetic drugs, surgery, high-tech interventions, was heavily financed, even shaped, by the fortunes of industrial titans like Rockefeller, Carnegie, and Morgan back in the early 20th century.
Yeah.
How did that supposedly impact the system we inherited today?
Well, the analysis presented in the sources is that this sudden, intense interest in medicine from the oil and steel industries wasn't purely philanthropic. It was clearly driven by business interests as well.
How so?
Oil byproducts, for instance, provided the chemical basis for a whole new generation of petrochemical drugs. This offered potentially immense profit opportunities from patented drug interventions. And this focus on chemical intervention is, structurally, the direct opposite of the lower cost, often preventative and nature-based homeopathic or naturopathic methods that were actually quite prevalent back in the 19th century.
So the argument is that the very foundation was deliberately built to favor expensive, patentable interventions, which connects directly back to that $192 billion overtreatment problem we discussed right at the start.
That's the connection the sources draw, yes. That the system was structured from its inception to prioritize intervention, volume, and high-cost technological solutions, which inherently drives inefficiency and overall resource allocation if the goal is purely population health.
And how is this shift accomplished? How did that model become so dominant?
According to these sources, this industrial takeover, if you want to call it that, was largely accomplished by gaining control over the very foundation of medical practice, medical education itself.
Control over the medical schools. How significant was that control?
Immensely significant, according to this analysis. By funding and thus influencing medical schools through foundations, they were able, supposedly, to drastically reduce the number of medical training institutions in the U.S. from around 650 down to just 50 by the end of World War I.
Wow, that's a massive consolidation.
Huge. And in doing so, they effectively extinguish or marginalize schools that didn't teach the specific allopathic fundamentals focused on drugs and surgery. So if you wanted to become a licensed physician, you increasingly had to adhere to this standardized drug-focused curriculum.
Creating a kind of powerful choke point.
Exactly. Ensuring the perpetuation of this intervention-heavy, drug-reliant model that, not coincidentally, financially benefited the industries providing the funding and the products.
Now, the source material goes further, suggesting this motive extended beyond just the financial profit from petrochemicals and drugs.
It did. And here we have to be very clear, we are impartially reporting what the sources allege. The analysis suggests that for some segments of the economic elite involved, the motive extended to broader concepts of power, social control, and even social engineering.
How so? What evidence do they cite?
Well, the sources tie this effort historically to ideologies like eugenics and depopulation efforts. They point, for example, to John D. Rockefeller III, founding the Population Council back in 1952. And he appointed the leader of the American Eugenics Society as its very first president. The stated goal, as cited directly in the source material quoting internal documents, was the rather profound ambition to control the fundamental processes of biology, encompassing everything from birth to death. The sources interpret this as demonstrating a long-standing pursuit among certain elites of systemic power over populations, using medicine and public health as levers. Again, this is the analysis presented in our source material. Hashtag tag 3.2 Healthcare and Entrenched Inequality, the UK example. Okay, now let's shift focus slightly, but staying with these themes of power and systemic issues, let's look at the struggles of a universal healthcare model like the NHS in the UK. It faces incredible pressure, not just from rising costs, but from the same macroeconomic realities we've discussed, often compounded by internal resistance to efficiency changes.
Right, and we see that the challenge of just affording healthcare, even in a universal system, is magnified by wealth inequality. Our sources note the UK has one of the highest wealth gaps in the developed world, second only to the US, and this inequality, as one source puts it, casts a shadow over all aspects of life, definitely including health.
Yeah, the NHS, it was conceived back in 1948, really in a moment of post-war egalitarian spirit, built on that core principle of universal care, free at the point of delivery for everyone.
A noble ideal.
Absolutely. Yet today, it faces just perpetual, almost existential stress, from rising medical costs due to progress, from funding levels that consistently seem to trail the actual demand, and from intense political pressure to modernize and become more efficient while somehow retaining its core universal principles. It's a constant tightrope walk.
And there's a current fear, isn't there, that the NHS is on, quote, shaky ground, particularly concerning fragmentation and maybe privatization by stealth?
That fear is definitely palpable, and it seems to have been amplified by the recent pandemic experience. We see evidence of the widening gap between the resources the NHS has and the needs of the population. This pressure is accelerating shifts towards things like digital consultations, GP Online, and significantly, the increasing use of third-party commercial contractors to deliver NHS services.
Which makes it feel less like one unified service.
Exactly. That fragmentation makes the NHS feel less like a single, coherent public service and more like a kind of composite system managed by different entities. And this creates new layers of complexity, new potential efficiency losses that actually start to mirror some of the fragmentation issues we see in the heavily privatized U.S. system.
And when commercial contractors get involved,
Well, the core motivation inevitably shifts, at least partially. It moves from purely delivering the best health outcome for the patient towards also needing to manage financial risk and maintain profit margins for the contractor company. That inherently introduces administrative friction and can potentially conflict with pure efficiency or patient need.
and this complex politically charged structure means that attempts to introduce potentially radical efficiencies, even those aimed at saving the NHS billions and improving care, can be fiercely resisted by the entrenched power structures within it. We have a really powerful, specific example of this in our sources concerning Dr. Srivatsa again.
We do. It's quite a striking story. Our sources detail the case of Dr. Kadiali Srivatsa, the same person behind the Dr. Maya GPT methodology. Through his clinical work within the NHS, he apparently identified numerous cases of what he considered negligent care, and he pointed these out directly to the relevant authority, the Surrey Primary Care Trust at the time.
So he was acting as a whistleblower, essentially.
It appears so, yes. And alongside this, he was developing that simplified diagnostic system we discussed, the color-coded symptoms, precisely to try and drastically reduce wasted consultations and cross-infection risks, a potentially disruptive efficiency reform aimed at saving the NHS significant resources.
Okay, so what was the reaction from the NHS establishment to him raising these concerns and proposing this efficiency innovation?
Well, according to the claims in our sources, Dr. Srivatsa was effectively victimized after he highlighted this allegedly negligent care. His innovation, the simplified diagnostic system, was apparently stifled by people in positions of power within the NHS.
Why? What reason is given?
The sources allege that this was supported by the General Medical Council, the doctor's regulatory body, and the aim was, allegedly, to protect the political structure, specifically citing the Secretary of State for Health, who had overseen policies like licensing nurses to perform roles previously done by doctors. Raising fundamental questions about care standards was seen as politically damaging.
And this escalated. It
Yeah.
resulted in legal action.
Yes, according to the sources, Dr. Srivatsa felt he had no choice but to file a case alleging torturous conspiracy against these bodies in the High Court.
Torturous conspiracy. That sounds serious.
It is. The sources state that despite the immense hurdles and personal hardship he endured, and apparently despite ultimately winning the legal points of his case, he was eventually forced to settle out of court.
Why settle if he won?
Because, the sources claim, the process had left him financially bankrupt. He simply couldn't afford to continue the fight. This specific sourced account really illustrates the immense personal and financial risk that can be involved when an individual clinician attempts to introduce radical, efficiency-focused reforms that challenge the established complexity, the professional boundaries, and the political power dynamics within a massive state-run healthcare system like the NHS.
That's a sobering story. But despite that experience, he was determined to bring change through empowerment, wasn't he? Using his knowledge.
Absolutely. The source material emphasizes that. It states he was determined to ensure future generations wouldn't suffer similar hardships or face such barriers. He shared his diagnostic insights in his book, The Art of Self-Diagnosis, and collaborated to create the Dr. Maya GPT tool precisely to try and reduce fear.
What kind of fear?
Fear of failure, fear of the law, fear related to religion, but centrally, fear of illness and infection. He believed this fear often made humanity surrender their free will when it came to health. So the goal is empowerment, enabling people to conquer that fear, make informed decisions for themselves.
Which in turn could reduce both the culture of dependency on overloaded healthcare systems and maybe even help alleviate the poverty created by systemic inefficiency and complexity.
That appears to be the driving philosophy behind his work, yes. Linking individual empowerment directly to tackling systemic issues.
You know, the final, perhaps most tragic reflection of this systemic failure, whether we're talking about the market-driven U.S. system or the universal but strained UK system, is the sheer scale of health inequality that persists across the board.
It really is a disaster, frankly. The UK's entrenched class system, for example, leads to just severe health disparities. It's shocking. People living in the most deprived areas of the country die, on average, a full decade earlier than those living in the wealthiest parts.
A decade of life lost based on postcode.
Essentially, yes. And it's not just lifespan. These poorer communities also spend significantly more of their shorter lives battling chronic illness and disability, often because of systemic issues stacking up against them. Maybe lacking the ability to work from home during health crises, living in more crowded housing with higher infection risks, suffering disproportionately from budget cuts to local public health services. It all compounds.
Which brings us right back to the core economic struggle of many working people, who are often forced into relying most heavily on these very healthcare systems that are themselves struggling under the weight of inefficiency and demand.
Absolutely. Poverty is growing, even among people who are employed. One source cited the poverty rate among working households in the UK being at its highest level ever recorded.
People are working, but still can't make ends meet?
Right. Forcing maybe 1 in 6 employees, according to one study, to struggle to pay basic bills, often driving them into taking second jobs just to survive. And this relentless cycle of poverty and stress inevitably deepens their reliance on the very healthcare systems, whether it's the underfunded NHS or the overburdened EDs in the US that are already struggling to cope with excessive demand, underfunding, and those deep-seated inefficiencies we've been dissecting. It's a vicious cycle. #tag outro.
So after all that, what does this all mean? We've taken a pretty deep dive into this paradox of modern healthcare, haven't we?
Really have.
We've seen clearly that billions, even trillions potentially, are wasted on inefficiency. Everything from that $192 billion in overtreatment to $180 billion just in administrative complexity and
So
paperwork.
just staggering sums.
But we also know the precise strategies that could recover those funds and drastically improve patient outcomes. We talked about the massive potential of health information technology, the crucial shift to value-based payment models, and the absolute necessity of better care coordination. The solutions seem known in many ways.
They do.
Yeah.
And the paradox is just so striking. On one hand, medical innovation continues marching forward, making surgery less invasive, developing safer devices like the Vena iCan, allowing people to recover faster and go home sooner. Real progress. But the foundational roadblocks, they remain enormous. Those high administrative costs haven't vanished. The fragmentation between providers is still a huge issue. And those historical profit motives, the ones that arguably birthed the current intervention-focused system, they still exert immense influence.
So it feels like we're constantly innovating in the actual delivery of care, while simultaneously being dragged backward by this systemic inertia, by resistance to fundamental change.
That's a good way to put it. And that resistance often comes from within the political and administrative structures themselves, as illustrated by the challenges faced by would-be reformers like Dr. Srivatsa when they tried to implement changes that threaten the status quo.
We've explored the structural, the political, the historical forces. We trace the system's roots back, according to some sources, to corporate power and maybe even control over knowledge itself. So the ultimate question we're kind of left with is, can genuine efficiency and universal health, like the success stories sometimes seen in countries that reform during moments of deep crisis, can that ever be fully achieved in systems whose core foundations were built not just on medicine, but arguably on the pursuit of immense corporate power and the maintenance of profitable complexity?
It's the multi-trillion-dollar question, isn't it? And we identified that empowering individuals with knowledge about that basic health literacy, the goal behind innovations like Dr. Maya GPT, is potentially key to recovering maybe $73 billion annually just by helping people navigate the system better and challenging that culture of dependency.
Right. Knowledge is a cost saver.
So here's a final provocative thought for you, the listener, to mull over. If maximizing personal knowledge and self-determination is so critical to improving the health system, to reducing unnecessary utilization and cost, does the system, perhaps by actively maintaining its complexity, by resisting simplified methods, by making information hard to access and understand, does it actively choose confusion and fear?
To maintain the existing power dynamic and the profit motive.
It's something for you to think about or maybe explore further on your own. How much of the inefficiency is accidental and how much might be structural?